Thank you, Sharifa. Good morning again. Yeah. Okay. 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 The first slide. Malaysia's pluralistic healthcare system. The this captures some aspects of what I like to call Malaysia's pluralistic healthcare system. Okay. Some other dimensions. Okay, will come up in the subsequent slides. Okay. But here you see the usual categorizations. Just largely taken from Ministry of Health, Health Facts 2025, which uses data from 2024. Okay? And there's one bit of information from earlier publication by Dr. Yap Wei An, okay, and his colleagues from 2019. Okay, I won't go through these slides in detail. By the way, let me mention that I will be sending a link, okay, to all the attendees, okay, to this slideshow. So don't worry about, don't concentrate on jotting down statistics and data from this, because I'll be sending it to all of you. Okay, yeah, just so so you see the distribution between public and private sectors, clinics, hospitals, doctors, outpatient utilization, inpatient utilization. I okay. I think the one thing which I want to point out, okay, the on the outpatient utilization, okay, what I did get from the Ministry Health Facts 2025, okay, were outpatient attendance uh, in the public sector, which was about 66 million in 2024. Okay, now the outpatient attendances in the private sector, the ones that were tallied, okay, were attendances at hospitals, private hospitals, because I suppose they're more reportable. Okay, the GP clinics, there are much too many. Maybe somebody from KKM, okay, can refer me to, maybe I missed, okay, data source, okay, on outpatient attendances in the private sector, again, in GP clinics. But anyway, I wasn't able to locate that. Okay, so what we have are 3.6 million, okay, outpatient attendance at private hospitals. Okay? But what was available, okay, from from 2015, which was reported in Yap Wian's presentation in 2019, okay, which he got from the National Health and Mobility Survey, okay, done by Institute of Public Health in 2016, okay, was an estimate of the proportions, okay, between public and private, okay, as far as outpatient attendances. And this, as you see, okay, it's 60-40%, okay, 60 in public and 40 in private. Okay, I'll just, if I tarry too much on this slide, I won't have time. Okay, from the same MOH Health Facts 2025. Okay, you see the financial allocations for this year, 2025. Okay, 45 billion ringgit. Okay, 45.3 again total, uh, uh, divided between 38.5 for operating expenditures and 6.7 billion for development expenditures. Okay, and as a percentage of the national budget allocations to KKM, okay, was 10.7% again. Now, in terms of national health accounts, again, the total national health expenditures, again, in 2023, 84 billion. And you see the split, again, between public and private in the last row, okay, the last row. In 2021, the public sector accounted for 57, almost 58%, okay, of total national health expenditures. Not surprising, given that was almost the peak of the COVID, okay, and it's since come down to about 52% again, 2 subsequent years. So total expenditures on health as a percentage of GDP, okay, and again in 2021, okay, went up to 5%. That's total, public plus private, okay, but in the subsequent 2 years, it's come down to 4.5% roughly. Yeah. Okay, healthcare financing in terms of sources again. Yeah. Now, when we say Ministry of Health, it means Ministry of Finance. Okay, it means basically government revenues. Okay. Ministry of Finance, Ministry of Health, okay, accounting for 43% of expenditures in the year 2017 of total expenditures. Okay. The next largest pie segment, okay, was private household out-of-pocket expenditures, 38%. And then you have, aside from the Ministry of Health, other federal and states agencies accounting for 7%. That's mainly Ministry of Education with the teaching hospitals, Ministry of Defense, the military hospitals. And I'm not sure whether there's still many municipal state health facilities. Not many, I think. Yeah. Social, SOCSO, again, accounted for 1%, private health insurance 7%, other pool private financing, mainly employer health benefits, employment health benefits provided by the employer through insurance. Yeah. Yeah. Okay, Jihan, I have to thank Jihan for this slide. Okay? Borrowed from him, yeah, from 2019, and this allows you to get a comparative idea, okay, of where Malaysia stands. Again, this data from 2016, okay, where Malaysia stands, okay, looking at total national expenditures as a percentage of GDP. That's the blue bar. The red bar would be total government health expenditures as a percentage of total government expenditures. Okay, so that's Malaysia, okay, South Africa, and Thailand, which sort of bracket Malaysia again, on the borders of middle income countries and upper middle income countries. Okay. So that's how Malaysia compares again with two comparator countries. All right, here's a mapping, okay, from 2013, okay, from the Ministry of Health, okay, the distribution of government health clinics, and on the right hand side in red, okay, private health clinics. And I think the patterns are fairly obvious. The blown up map portion, okay, of Wilayah KL, okay, you see concentration of the private health clinics there. And but the distribution of clinics outside of KL, okay, it's not terribly different. There's some difference, but not very dramatic. Okay? On the peninsula, again, the dramatic difference is on the in the East Malaysia, again, Sabah and Sarawak, where you see much fewer private health clinics, but the population is much smaller. Okay? Now, in terms of distribution of hospitals, again, okay, you see this difference in spatial distribution, okay, between the private hospitals and MOH hospitals. Right. Now, this is a slide which I've had much occasion to use lately. We see here the total health expenditures as a percentage of GDP. Again, this is from 2019. Government health expenditures on the bottom as a percentage of GDP. The bars, okay, the gray bars, I think that's fairly legible. Malaysia, that's the figures for Malaysia. The blue bars, perhaps not very legible. Okay? Bad color choice. Refer to UMICs, okay, upper middle income countries and Malaysia is categorized as such, okay, upper middle income countries, and the in beige, okay, the high income countries, okay. So for Malaysia, you can see in the top row, okay, look, comparing Malaysia's total health expenditures as percentage of GDP compared to UMIC average and the high income country average. Okay, the bottom row, okay, government health expenditures, okay, in Malaysia it means largely KKM health expenditures as a percentage of GDP. Okay, 2019 for Malaysia it was 2.2% of GDP. Okay, yeah, government health expenditures. The average for UMICs, okay, upper middle income countries, 4.4%. And for high income countries, at 6.4%. Right? So in other words, in 2019, okay, as a percentage of GDP, the Malaysian public sector healthcare expenditures were half that again of the UMIC average, 4.4%. Um, a while ago, I wanted to borrow a slide from Debbie. Okay? No, okay. I decided not to flash that, but I will refer to the figures again. So Debbie is saying, they're saying, no, 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 don't use it yet. I'm waiting to update it for 2023. The figures that she presented about a few weeks ago at another meeting were from 2022. Okay, now the figures at that time, okay, 2022, the Malaysian government expenditure as a percentage of GDP, okay, was 2%. Okay, in 2022, for UMIC average, okay, in 2022, okay, was 3.1%. Okay, but she made a very important point, okay, and that is that Malaysia is on the verge of becoming a high-income country. Okay, so we should be on the high end, okay, of the UMIC spectrum. Okay, and the 2022 expenditure as percentage of GDP for not HIC but OECD countries, okay, which was what you had, okay, was 8.3%, okay. So Malaysia currently should be on the low end, okay, low end of the OECD distribution with the average at 8.3%, and we should be on the high end, okay, of the UMIC average, okay, which was 3.1% in 2022, okay. So we're spending 2%, okay. We're spending, Malaysian government sector is spending 2% of GDP, okay, where it should be considerably above 3.1%, okay, and slightly below 8.3, 8.1, 8.3. Okay. No, all right, that's fine. I'm just calculating the figures, yeah. To put you on the spot again. So that emphasizes further again how much we are under in comparison with this norms. Okay, the these norms around the world. Okay? We are just to stress the point that we are severely underfunding. Okay, the public sector, and this is not just in 2022 or 2019. Okay, this has been chronic again for the last several decades. Okay. Now, notwithstanding again the 2%, okay. In fact, post Merdeka, ever since 57, okay, the government expenditures, okay, on healthcare have been hovering around many years and below 2%, okay. Certain years, especially during COVID, okay, shot up, okay, understandably, okay. But in most years, it's hovering about 2%, okay. Very seldom, a few decimal points above 2, okay, in many years below 2%, okay. But even so, with that very modest allocation, okay, to the KKM, okay, in the first few decades after Merdeka, okay, the expenditures, they were expended on well-chosen, low-cost public health interventions, okay, of which I've listed some of them here. Okay, village midwifery, for instance, the bidan kampungs, okay, which was the government had a scheme for bringing in the bidans, okay, for short-term intensive courses, okay, so as to upgrade the skills, okay, in handling births, okay, in the kampungs, okay, and eventually they were actually absorbed, okay, into KKM, okay, as full-time staff, okay. There were vaccine preventable childhood ailments efforts in that regard. The Tandas Chura, okay, pour flush latrines, okay, what were referred to as the Jitra bowls, okay. Jitra in Kedah, okay, because it's introduced in the Muda irrigation scheme. Jitra bowls, okay, pour flush latrines, okay, apply food and nutrition program, potable water supply, environmental sanitation, control communicable diseases. And if you want to extend into social and ecological determinants of health, even things like rural access roads, okay, rural electrification, all this have population health impacts, okay. So because even with the modest 2%, okay, we managed to achieve quite creditable, okay, improvements, okay, in our population health, okay, from the 60s onwards. In fact, pretty much from Merdeka, okay, in 1957, okay, you can see a steady improvement, okay, in life expectancy of birth, okay, for males and female. Yeah, from the 60s up until the latest year, which was available in this graphic, 2015 again. Okay, child mortality rates steadily falling again from 1963 to 2013, and maternal mortality ratios again constantly dropping, and um, level off is sort of level. Let me take advantage of Debbie's presence here. Debbie, some years back, okay, during World Health Day, Doctor not Rajkarim, Narima Awin, okay, who used to be head of MCH unit within KKM, okay, she said that when she was head of MCH in KKM, okay, that maternal deaths, okay, that were reported to WHO, okay, included only citizens, okay, they did not include maternal deaths occurring among non-citizens in Malaysia, okay. Um, is that has there been any revision to WHO's reporting protocol, or within, or has KKM, okay, changed its guidelines, okay, for reporting WHO? Because there are I think legitimate concerns, okay, that maternal deaths among migrant women, okay, especially among undocumented migrant women, okay, quite underreported, okay. And I'm just wondering whether the leveling off, okay, was because there was a change in reporting protocol, okay, guidelines. Okay. Okay. Mhm. 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 Because at one time there was concern that it was all leveling off. Yeah. Okay. 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 Now that was a fairly positive, creditable portrayal again of Malaysia's achievements again in population health, the steadily increasing life expectancy, declining childhood mortality, declining maternal mortality. But the situation is much less satisfactory again if you look at life expectancy at age 60 again. In other words, if a Malaysian citizen's average Malaysian reaches survives up till age 60, what is your life expectancy from age 60 onwards again? And here you see the divergence again. A very, very troubling divergence. The lower line, okay, of course, again, is Malaysia again. The other countries for comparison in this graphic, okay, Japan, Australia, Singapore, Hong Kong, New Zealand, Taiwan. Okay. So if you compare Malaysia's life expectancy, okay, by 2012, and you notice it's a diverging trend again. Compare Malaysia with countries like Taiwan, Hong Kong, Singapore. Few decades back, we were pretty much at the same level again. But a few decades on again, there's a divergence, and now the difference, you can't you don't. I've measured it is about 5 years again. That's a lot, A 5 years difference again in life expectancy again at age 60. Okay, and I think this is a population health evidence demonstration of what Debbie was mentioning earlier. Okay, um, okay. Sorry, this is female life expectancy. The earlier one was male life expectancy. Same thing again with females. Okay, a, a gap. Okay, we're lagging by about 5 years life expectancy. Okay, comparing to countries that we used to be at the same level with. Okay, few decades earlier. All right. And I think it's quite persuasive, okay, that this has much to do, okay, with our ongoing epidemics, okay, of NCDs, okay. Um, these are figures from 2013, okay, prevalence of overweight and obesity, okay. And Malaysia, of course, okay, among the Southeast Asian countries, okay, ASEAN countries, okay, It's the highest, okay, prevalence, okay, of obesity and overweight. Okay, now, um, again, okay, we're back to this graphic, okay, our chronic underspending, okay, of the in the public sector, okay, right. So, the primary healthcare PhD, okay, of an earlier era, okay, the first few decades after Merdeka, they may have been adequate, okay, in a situation when your disease burden, okay, is largely infectious disease, malnutrition, okay, maternal deaths, okay. Many of these were what clinicians would call acute episodic self-limiting diseases, okay. So with well-chosen lower-cost interventions, okay, you could have um, quite significant impact on population health, okay. But now, okay, we are grappling with NCD, ongoing NCD epidemics again. We are undergoing this epidemiological demographic transitions, and the 2% GDP, okay, for the public sector, okay, can't cut it, okay. It's severely underfunded for us to cope with this multiple epidemics, okay, we're faced with NCDs, okay. So to cope with the current epidemics, society, including CHI, campaigning for a doubling of government healthcare spending to 4% GDP over 5 years to be spent on comprehensive primary care, healthcare with referral backup, GP capitation payments, recruitment and upskilling of staff, expanded treatment modalities and upgraded facilities equipped with IT-enabled accessories, augmented medical consumers. You can see I'm reading from some manifesto that we've presented on past occasions. I'll skip the other two bulleted points. I had an occasion, okay. An opportunity, okay. I think it was in 2019, okay, to put a question to Tan Sri Dr. Abu Bakar Sulaiman, our longest serving Director General of Health, okay. I asked him, it was at a panel, okay. I was moderating the panel. I said, Tan Sri, can you, from your long tenure, okay, as a DG Health, okay, can you tell us what were the main obstacles you faced, okay, on the many occasions when you requested through your health minister, okay, for increased allocations, federal allocations, okay, for KKM, okay. He thought for a moment and told me, Chee Khoon, invariably, okay, at those cabinet meetings, okay, there would be somebody from Treasury or the Ministry of Finance, okay, who say that the federal government feels it's very important to maintain an attractive climate for foreign direct investment, okay. We must maintain, because we're competing with neighbors in the region as well as other countries, okay, for FDI, okay. So it's as part of the attractive incentive package, okay, to draw in FDI, okay, to maintain a low taxation regime, okay, translates into low corporate taxes, low income taxes, okay. So in other words, that the implications are that our fiscal capacity is reduced, okay. But I think Tan Sri gave only one part of the answer, okay, because there was concurrently, okay, active encouragement of for-profit healthcare, okay, with tax incentives and subsidies to cater to, quote-unquote, market-capable segments of society, okay, thus allowing the health ministry to concentrate its limited healthcare resources on the, quote-unquote, really deserving poorer citizens. Now, this targeting approach, okay, had considerable intuitive appeal, okay, as the persuasive face and generic template for the privatization of essential social services. In healthcare, it is a recipe for a two-tier system, that is, deluxe priority care for the rich and a rump underfunded public sector for the rest. Okay, I'll skip the last bullet point again. Yeah. So now, the situation with that encouragement, okay, creating some space, okay, for the growth of for-profit private sector, okay, resulted in accelerated development of the private hospital sector in particular, okay. I won't go into some of the chronology, okay, of how the government itself, okay, not just creating a conducive and encouraging environment, okay, for the emergence of private hospitals, but the government itself, okay, eventually acquiring, okay, many of these private healthcare assets, okay, and it's now come to the point, okay, where the federal government, okay, through its sovereign wealth fund, Khazanah, okay, is among its portfolio, Khazanah's portfolio is its healthcare assets, okay, grouped under the umbrella Integrated Healthcare Holdings, okay. From the early 20 teens, okay, over a period of about 5 years, okay, Khazanah started acquiring healthcare assets and merged them under IH's umbrella. And it's not just healthcare assets in Malaysia and Singapore, like the Gleneagles Parkway, Gleneagles chain Parkway, which has now been merged with the Pantai chain of hospitals, okay? But it's also been acquiring assets abroad, okay? And it's now gotten to the point where IHH, okay, is now the second largest listed private healthcare provider in the world. Second only after the Hospital Corporation of America. So in other words, Khazanah through IHH, okay, is a huge player, okay, on the global healthcare scene, especially proprietary hospitals. Okay, I have only a couple of minutes left, okay, and I will skip this. Go on to this. Now, in the recent years, okay, there's been revived talk, okay, of the need for healthcare reforms and privatization, financing of healthcare privatization, etc., okay, and related matters, okay. And there's been debate, for instance, okay, over social health insurance, okay, as a possible means of financing a large portion, okay, of the Malaysian healthcare system, okay, but lately receded to the background, okay. So the Citizens Health Initiative, okay, has somewhat different ideas, okay, about how our healthcare financing scenario should evolve, okay. So these are two competing visions, okay, for Malaysia's pluralistic healthcare system and its financing, okay. What we would like to see, okay, CHI and a number of other civil society organizations, okay, we would like to see expanded public provision of highly subsidized, widely accessible, timely, no-frills quality care, okay, funded by more progressive income and corporate tax regimes, including wealth taxes, property and capital gains taxes, Tobin-type taxes, which can compete with the private sector, or at the very least, act as a fallback option or price bulwark, okay, against escalating charges in the private sector, okay. As opposed to that, again, the other option of social health insurance, okay, which in its earlier proposals, okay, was in the form of a proportional payroll tax, that is, a de facto supplementary regressive income tax, a ring-fence health tax, with matching employer contributions, and it would be integrating an overburdened public healthcare sector with underutilized private sector, okay, through a unified provider payment system, possibly involving capitated primary care, okay, and maybe some hybrid of the above. So in other words, social health insurance, again, the second scenario, okay, is an attempt to deal simultaneously with two distinct problems, okay, how to raise more money for natural health expenditures through this proportional payroll tax, okay, and at the same time integrating an overburdened public healthcare sector with an underutilized private sector through a unified provider payment system, perhaps a DRG based, which can rationalize utilization of services across both sectors, okay. This expands further, okay, on Citizens Health Initiative's ideas and proposals, okay. We think that there are better solutions, okay, than SHI, okay. I've I think circulated a video, okay, to all the attendees, okay, video actually from WHO, okay, which summarized the the findings from a paper that was published in Health Affairs, okay, discussing the advantages of tax-funded healthcare, okay, over social health insurance, okay, in low and middle income countries, okay. So we, in line with that, 1 minute left. Thank you. Yeah. So we prefer a dedicated, ring-fenced tabung kesihatan solidarity. Some of you might notice that it used to be called tabung kesihatan negara, okay. But I think I like the term solidarity. Tabung kesihatan national health solidarity fund. Yeah, okay. Funded by supplementary progressive health tax cooperating, same thing which I mentioned earlier. Okay, but importantly, subject to robust governance provisions, stakeholder representation, accountability, and transparency. What would this national fund be used for? To reinvigorate public provision of healthcare, expand delivery capacity. You can recruit a contract for more staff, strengthen comprehensive primary care, continuity of care, to deal with our increasing burden on NCDs, better management of staff, in terms of employment and benefits, promote better transparent criteria and processes for upskilling, promotions, career prospects. Okay, to slow down the perennial outmigration of senior experienced staff. Okay. Now, where shortfalls in delivery capacity of the public sector may exist, spillover patients from public hospitals could be channeled to quote-unquote panel private hospitals in accordance with DRG-based fee schedules and case mix-based institutional grants. KKM could be bulk purchaser of supplementary or top-up services from the private sector at negotiated discounted prices required of licensed private providers, much like housing developers being required to fulfill a certain quota of low-cost housing. Okay, that's the end of it. Thank you.
Thank you. Yes, please, sir. Go ahead.
Okay. Hi, this is Raymond again. Quick question to both. Thank
Can
you
you
for.
introduce yourself?
My name is Raymond from Private Digital Health segment.
Okay.
Just a quick question to both. Very
Both.
good, insightful presentation. In your opinion, we talk about capitation model, which incorporating value-based healthcare elements, right? What are the strategic actions that needs to be taken in order for us to move towards the capitation model in view of the current dual payment system in Malaysia? So of course, benchmarking or referencing other countries which actually practicing capitation model. So what are the strategic actions that need to be taken? Some tangible actions, right? So we have been talking about value-based, talking about capitations, but what are the strategic actions needed to be taken care of, especially looking after the primary care sectors and and the whole environment? Thank you.
Thank you, Raymond. May I invite Dr. Chan first? Maybe you want
I'm
to.
so sorry,
sorry.
Prof. Sorry, can I just ask before you address that? I don't come from a
Ask.
health background. Can you explain what capitation means?
Right. Okay.
Thank
So
you.
that's a good one. Yeah. Maybe Dr. Chee, you want to start it, and then maybe Dr. Chan can talk about the financing method. Go ahead. So the question is, what is capitation and strategy actions?
Yeah, actually, capitation system is a good example is the NHS in UK. Capitation system is a system where general practitioners contracts with the National Health Service. So the National Health Service has a contract with either a group practice or GP to provide healthcare for a designated number of patients who are registered with that GP. So the patient catchment should be more or less stable lah. Of course, there are movements here and there, and for the services that are provided by the GPs to these patients is essentially paid for by the health service.
Does that answer your question? Maybe, Debbie. Yes, please go ahead.
If I can just... so capitation actually just means that you pay on a per person basis. So there are different ways of structuring capitation, but a capitation payment system means that you pay for a certain package of services to be delivered on a per person basis. So that can be a catchment population. So you can have a population, what we call population-based capitation. So if you're in a very stable population where you've got, okay, one clinic for this sub-district, for example, in a country, then you can, capitation can be that population, but then you have all of the cross-border issues. What often happens more is that, and it's really this mechanism to try and create competition as well between primary care providers. You'll have a system that's called empanelment, which is where a person will register with one, and in some countries it can be up to 3, so it doesn't only have to be one, will register with a primary care provider, and then they will be paid based on the number of people registered with them. So the literal capitation payment is just that you're paid on a per person basis, per capita, hence capitation. But then, so that has a lot of good incentives in it. What it doesn't do, you can imagine, like, if you just got paid per capita and then you got to keep whatever you didn't spend, which is often what happens, then there's incentives to under-provide care. So if I just get, okay, all these people have registered with me, but I get to keep whatever I haven't spent, which is why we usually say that we work on the basis of a performance-based capitation as well, where we have certain indicators in there that say, okay, you also need to achieve these targets, etc., as part of the capitation basis. Okay, sorry if that's okay.
Yeah, thank you, Debbie. At the moment, we don't have it for the national level. We don't have it yet. Most of our so-called GPs are paid either by person. So the PERCA B40 sort of, tried to sort of facilitate that, but it's still covered by the government. And that's not, in a way, it's not even per GP. It's based on their, sort of reimbursement by the provider, which is the GP, the private GP here. Can I pass to Dr. Chan if you want to touch on Raymond's question just now?
Yeah, let me touch on the aspect of family medicine, okay? I think you may or may not agree with this, okay? But perhaps there needs to be some degree of upskilling, okay, of family medicine, okay, practice, okay. Now, I was teaching at UM, okay, in the medical faculty until 2016, okay. And as of that time, okay, the impression I got from my colleagues, okay, in the department of SPM, okay, was that the numbers of family medicine specialists, okay, in KKM, okay, was very low, okay, in contrast to MOs, okay, MOs without further training, upskilling, okay, in family medicine, okay. So that's one issue, okay. I think Heng Ling presented some figures, okay. So the numbers of family medicine specialists, okay, are inadequate, okay, for proper primary care, okay. Notwithstanding that, the Harvard consultants, again, in the reports, again, mentioned clinical audit, again. I don't know whether it was randomly selected, but they did a comparison, okay, of primary care practice, okay, in the private sector, okay, with KKM, okay, primary care. And I think, although I'm not sure, okay, that the ones that selected from KKM were actually the family medicine specialist, okay. So perhaps not surprisingly, again, they found that actually the KKM primary care doctors outperformed, okay, the GP primary care providers, okay, which were who were selected, okay, in terms of accuracy and diagnosis, medications, okay, medication regimens, etc. Okay, so so there's an issue of increasing the number of family medicine specialists in KKM, as well as upskilling, okay, the average level, okay, of GP practice, okay, primary care in the GP sector, okay. Now, added to that, and this is anecdotal, okay, perhaps you can share from your own experience, okay, in the private sector, okay. I'm told that in some of the major urban centers, KL, maybe Penang, JB, okay, that if you wanted a location of your practice, okay, in urban areas, it's very expensive, okay, right, to rent or let alone to purchase, okay, a locale, okay, where you can set up your practice, okay. So in fact, many younger primary care providers are going to come out in the private sector find it very difficult, okay. Now, I don't know whether that's leading to a situation in which they actually are quite inclined, okay, to serve in KKM, okay, as medical officers, okay. But in fact, we've heard again that that is getting increasingly difficult getting permanent positions again in KKM, okay. So so I don't know whether that might in time, okay, sort of lessen the problems of the preponderance, okay, of primary care providers being in the private sector, okay, rather than in KKM, accelerate stuff, okay. But also, of course, that means you also have to upgrade the quality of care, okay, in KKM primary care. Yeah.
Thank you. Debbie, you want to add something on the process?
Yeah, just to go to your question about some of the things. So you specifically are talking about a transition to capitation. So two of the earliest things that need to happen. So one is universal in any country is the first thing that you need to do, because to develop that rate, the per person rate, you need to know what services that you want to ensure is delivered and financed under that system. So you first of all generally define a primary healthcare package that you want that capitation to be able to finance, and you cost that package. So that's the first thing. And you look at differentials in that cost based on like demographics. So for an older person, generally we know like women of reproductive age, children, older people, all of that uses more healthcare. So we make adjustments for those kind of things. So that sort of costing, that package definition and the costing and the adjustments. The other side of the coin that's always necessary is public financial management changes. So at the moment, you know, we've got a line item based system of paying, for example, the clinic kesehatan. Might be different when you're contracting. That's easier in terms of the GPs, but it's really important for the public sector as well. So there, the public financial management, there's a lot of negotiations in any country shifting to capitation that go on between Ministry of Health and Ministry of Finance usually to say, okay, can we shift from line item budgets, or, you know, shifting from fee for service even, but shifting from line item budgeting, where you generally have much more control over what happens to then a capitation system. All of those negotiations are really high priority as well, because that takes time.
Thanks. Can I quickly
May
respond?
I just want to add that one of the most important steps in transitioning is talking to the GPs, you know, and getting their buy-in. You know, in a way, you have to start that process very early and bring them along.
Yeah, sorry, I should quickly respond to that before Dr. Arasu. I totally agree. And I think the key thing is the alignment, right? Public and the private side on the GP, the interest alignment, the incentive alignment in order for the buy-ins, as well as the, you know, the literacy and also the policy, whether are we having the, you know, very strong political drive towards this new capitation model while we have been doing decades of, you know, FFS, right? So it's not easy. I mean, it's good to learn from, you know, other countries. How do they transition from that model? You know, like Indonesia is doing it, right? The capitation model, and having some success. But of course, there are also a lot of challenges. So something that we can learn, and which is also need to localize to our Malaysian population and, you know, the system as well. Yeah.
Just because I used to work in Indonesia. And, so just to be clear, a lot of the countries that have done it have started with public sector. So Indonesia, in that case, the capitation was done with the puskesmas, largely first. Mongolia has one of the best performance-based capitation systems around, also largely with the public sector, but now public and private. So there's also issues with that completely.
Yes, please go ahead.
Just,
Dato', go ahead.
I'm also a practicing GP. So I've done quite a number of studies, especially on GP demographics in the country. I think we've done the largest study in 2017, and it was published in the International Public Health Journal. It's on GP demographic. Okay, basically, number one, I think what Dr. Chan mentioned earlier is the Colico-PC studies. So Colico-PC study is the one that compared the performance of GPs and also the KKM, MOH clinics. Actually, the percentage difference is very, very small. It's less than 2%. And then we must also know GP see more acute cases compared to clinic kesihatan where they see more NCD cases purely because of economic reasons. Because who comes to the GP clinics are M40s and mostly B40s. Top 20 goes to the private specialists. Okay, the other thing is that why the GPs do not do specialization, there's no incentive. Because if you become a specialist, GP specialist, immediately you go under NSR, National Specialist Registry. Then automatically you go under the 13th fee schedule. So for the 13th fee schedule, for the specialist rate is that a consultation is 80 to 235 ringgit. So now the employees and the payors, they wouldn't want to pay 80 to 235 ringgit to see a GP specialist when they say, hey, I would rather see ENT, I better go and see an ENT specialist. A pediatric, I go and see a pediatric specialist. So definitely there is an issue of policy of which the government has to address. And second thing, if you look at the governance structure of the KKM itself, you have DG, you have deputy DGs. Now you have 4 deputy DGs. So the 3 deputy DGs, one is technical and scientific research, and you have one is Perubatan and one is public health. So currently under the public health as well, BPKK is there, Bahagian Perkembangan Kesihatan Keluarga is there. All this while, the head used to be a public health specialist. For the first time, they're having a FMS who is the head there, which is very good. But you have the Perubatan where you have Perkembangan Perubatan and then CCAPs. So they are the one actively regulating and micromanaging the GPs, but they're also supposed to perkembangkan. So the perkembangkan is only for the government sector. They do not perkembangkan the private sector. Okay, so there's an anomaly in the structure of which we have been talking about that. We were hoping that the health white paper would address it. Just a context to say why we are in this situation. And then there are multiple issues to be resolved. I mean, since the media is here, because we need all your help to actually put the pressure on the government and also educate the public where are the gaps and how can we improve with that. And the last one is that Dr. Chileng, actually almost I can say 90% of the clinics are GP clinics in the country. From the currently as at May, we have 11,490 GP clinics in the medical clinics. We can comfortably say 90% of them are GP clinics. The private specialist clinics are not many, except for those who are some, for example, the older way of a private hospital like Gleneagles and probably some Damansara and some Makota Hospital where the private specialists can buy the suit. They register under, those numbers are no more increasing. So those coming out to open in silo, also very little. So I could comfortably tell that 90% the thing is that it's in the public domain. The data is there. Unfortunately, you have to go through the Excel file and then for the 11,000 clinics, you got to filter it one by one to get the number. Thank you.
Thank you, Dato'. Yes. Yeah. All right. Yeah. Go ahead.
I don't know whether this is still pertinent, okay, but back in the early 1990s, okay, Tan Sri Baka, okay, together with Dr. Jai Mohan, okay, and there was a Chinese lady pediatrician, okay, but the 3 of them carried out a study, okay, on behalf of Academy of Medicine, okay. No, it wasn't Malaysia. It was another. Anyway, comparing outpatient specialist clinic in the private sector and in the government sector, okay. And they found that, not surprisingly, in the government sector, okay, outpatient specialist clinic, okay, saw mainly complicated cases because there's a gatekeeping referral from MO, okay. But in the case of private sector, okay, 3 out of 4, okay, of outpatient private specialists encounter, okay, in outpatient clinic, okay, were for conditions, quote unquote, trivial conditions which should be easily handled by a well-trained primary care practitioner. So, because of the lack of gatekeeping, okay, and referral system, okay. So in other words, it was they had spare time, okay, from other than dealing with the specialties, okay, but they were seeing primary care patients, okay, 3 out of 4 patients, okay, for relatively simple trivial conditions, okay. So I think this is an issue which presumably some kind of health financing system, okay, might try to address, okay, the underutilization, okay, of specialist expertise in the private sector to the point that they are actually spending time doing primary care, which can actually be handled by a well-trained primary care provider.
Yeah, I think the groundwork, I think Raymond, is already done by many sectors on the costing and things like that. But it has the second part of what they mentioned is probably still not happened yet, the political drive and things like that. The costing part on different benefit packages for outpatient and things like that, I think the cost is available from the public sector. Definitely some work probably needed for the private sector. I think the data is probably there as well. Yep. Okay, we don't have much time. Can I invite anyone else to present any questions to the speakers? Yes, please go ahead. Thank you.
Hello. Hi, my name is Lishan and I'm a lived experience advocate for mental health. My question is, the large question is, how might communities work more with primary care providers to quote unquote prevent diseases, including mental health issues? More specifically, I was thinking about like the referral system from community to primary care in terms of like maybe social workers who are house visiting, things like that. So this thing occurred to me, which is, are there actually, and my question might be coming from a place of ignorance, are there referrals from GPs to, say, community groups? For example, a GP could refer a patient to a running club or like a nature group that goes on nature walks, something like that. I think there are sort of a lot of discussion about like prescriptions for such treatments, but those prescriptions are to like individual patients, I guess, rather than bringing them back into the community. So yeah. So my question is, is there actually already this sort of bi-directional referral system in place, or could such a thing be implemented, and just throwing it out? Thank you.
Thank you, Chan. Yes. Anyone? On mental health and community work and mental health, that's the first part. And the second part is that how often or how applicable is the referral, especially for CSOs and NGOs related with this matter?
I'm afraid I do not know very much about mental health at all. So I really cannot answer that question. In terms of generally whether GPs, try to do health promotion, I think I came across in one of the studies that they do try to do that within their own limitations, within the limitations that they have. But I don't know, do you?
Yeah, Dr.
Can you
Chan,
answer that?
Dr. Chan, you want to carry on with the answer? I think
I
Dato'
can't
want
think
to
of
say as well.
any instance offhand. I can't think of any.
Yes, Dato', yes. Go
Thank
ahead.
you.
Very good question. Okay, let me speak first on the mental health. Actually, GPs, we do see lots of mental health cases, especially it's more prominent after the COVID-19. Okay, common symptoms are headache, repeated headache. When you ask a little bit extra question, then you'll understand they're having mental health issues, and many of them are minor one. So what MMA we have done is that knowing the issue of mental health, and GPs in a very good position actually as a first point of contact and close to the family, because we have done a study to show that based on the Qualico PC, a patient visits the outpatient 3.9 times in a year. So if you have a family of 4 in a GP clinic, they'll come with a wife, they'll come with a... So you can see they visit at least 10 times, maybe 4 times for treatment, another 8 times to accompany somebody. Okay, so based on this, we said we are better positioned. So we have actually approached Ministry of Health. Actually, we have done a paper, non-paper is all submitted to the ministry and then also approved, whereby we will train GPs for GP special interest in mental health management, very basic things. Okay, then we have also, we have put it to the minister, also approved. So now it's a paperwork in progress, so they'll be able to train more GPs who have interest in mental health, and then they can provide as a gatekeeper in managing that. And your second question in terms of prescription, of course, as a GP myself, I would say most of my colleagues, we do promote, because nowadays we know in every community, in a taman in Malaysia, you have lots of activities, either Tai Chi or hiking, all kind of activities, right? We do encourage them. Even though there's no formal structured way of referrals, but even these programs are done all in a very loose form, right? Somebody takes the ownership. So we do refer them, hey, why don't you join this group? Because GP is community-based. And most of our patients, 80% of patients are within a radius of less than 2 kilometers. So we know roughly where they're coming from. So this is what we do. And then, so these are the things, the referrals. So the system is already in place. Is that how do we, like what our Chan said earlier, how do we put a system, the basic thing what the government should do, which MMA also has proposed to them, that link the GPs with the clinic kesihatan and the government hospitals. So these are the basic things which doesn't have cost to the government, just to link a simple referral whereby you create a WhatsApp group between the GPs in that area with the clinic kesihatan with the emergency department. Has it been done? Yes. There's one hospital in Ishta, the ED physician that has been doing that for so many years, where he connected all the GPs in that area with the emergency department or Ishta. Any referrals, they can communicate directly. So that actually solves problem at zero cost. So these are the simple things actually government can do to create the network of GPs with the clinic kesihatan first and the hospital. There is some communication. So by doing that, like what Dr. Chan said, of course, currently there is no standard of care the same everywhere because there's no formal training for you to become a GP. So many of them, they go for courses on their own, right? So by doing this, you can also elevate the level of care because now you're communicating with somebody. So for our program for the mental health, so one of the proposals we told them is that, like in the 4C just now, right, you must have continuity of care. When you refer somebody, you must know what's happening to the person. Then you close the loop. So these are all in progress. So of course, with the political will, we hope to see that is being executed, not just keep talking.
Thank you. Yes, Debbie.
Just to make a quick comment, and you probably know this better than me, and I wish Isaac was here. So WHO has a mental health person as part of the WHO team who's Malaysian, Isaac, in the team. But so I know that the Ministry of Health have the Mentari centres, which are the community mental health centres as well, and they're aiming to scale those up further. Definitely, as we're looking at allied health, one of the challenges is in terms of particularly clinical psychologists. So in public sector, the mental health is quite psychiatrist driven, and so that availability of clinical psychologist at one stage and then counsellor for those ongoing support, and then obviously also the regulation of the social worker as well. So there's a few things there that I think in terms of the personnel to deliver, and I'm not disagreeing with the GP and the training, but in terms of some of those specific skills as well around mental health support, I think that availability of community mental health services, and you probably know that WHO has the MH GAP, which is the Community Mental Health Gap Action Plan. Those are things that definitely I think would be high priority to look at, not just for Malaysia, but for a lot of countries. So definitely the allied health services to support those mental health service delivery as well is really important.
Thank you, Debbie. I think mental health is a very big thing now, especially after COVID, and you have the possible effect of the long COVID as well. Just before that, maybe can I invite someone from Ministry of Health who has been here? Doctor at the back, yes. Can you touch on the services that's provided by the public sector, which is a lot on mental health? Yes. Doctor, tolong. Any one of you? Can you talk on coming from the Ministry of Health?
Hi everyone, my name is Dr. Arif. I'm coming here as an NGOs, but I'm also working in Ministry of Health. Basically, under Ministry of Health, we have what we call NCHEM, National Center of Excellence for Mental Health. So their role is basically to provide the policy on mental health, to provide the service in any facilities under the hospital or also KK lah, klinik kesihatan. So regarding the service between private and also government, basically we have such connection between them. It's just that we lack in promotion to the communities. I think this the important thing that government needs to do to promote the service provided by the government. Of course, this thing must be highlighted by public health, because clinics actually the service governed by the public health in Ministry of Health. So that's the thing that I can share for the time being.
Thank you, Dr. Arif. So does that answer your question, Chan? Somewhat, from the public and private sectors.
Yes, thank you very
Thank
much.
you. Yeah.
Sharifah, can I just
okay.
add on to Dr. Afif, okay? Dr. Afif. I think Arif, yeah. Aside from being KKM staff member, I think you're also with Ikram, right?
Yes, correct.
Yes, and actually, as in the earlier conversation, it occurred to me that one of the institutions which are naturally, could be quite relevant, okay, to such initiatives, okay, might be some of the faith organizations, okay. Yeah, I'm thinking, for instance, okay, of some friends and relatives of mine who are church members, for instance, okay, and some of them are medically trained, okay, who are involved in medical missions, okay, domestically as well, in certain cases abroad, okay. So they go into orang asli villages, for instance, okay, to provide various kinds of care, okay. And so those doctors or other health personnel, okay, within such faith organizations, like Christian, Islam, Muslim, or other faith organizations, okay, might be able to bridge that kind of gap, okay, between the conventional health professional, okay, and other kinds of community-oriented services, okay, both in mental and non-mental health areas. So, could you tell us a bit more about what Ikram might be doing, okay, in this regard? Okay?
Okay. Basically, Ikram is an NGO, a big NGO. Under Ikram, there is a wing for medical background. It's not just a doctor; it also included allied health. So that's we call Ikram Health. So basically, Ikram Health for now we are focusing more on reaching communities to increase health literacy, such as we actively teach community on CPR, and also we actively do health screening for the B40s, and also we have some like follow up for them once we do the screening. And this the thing that we do currently, because we also have limited numbers, those doctors and allied health that can do the volunteerism activities among Ikram. So that's the idea of Ikram Health.
Thank you so much, Dr. Chan, Dr. Chee, and also Dr. Arif, and of course, Debbie and Dato. So we have finished our Q&A session, and I pass back the mic to our Madam MC. Sorry. Yes.